over for this week's lesson. It is a bigger chapter because it deals with the entire periodontium. So it deals with the cementum, the alveolar process, and the periodontal ligament. So I have, my PowerPoint up so that we can discuss the different parts of, the periodontium. So any questions about the dentin, the pulp, or the enamel? Okay. How many are in your class? Are there 13?
I think it's 15.
Okay. Let me see who we're missing.
Devin said his is just spinning and he can't get in.
Yeah, well, I admitted him, but I don't know what's happening there. I'm gonna admit him again, see what happens. Thank you. Okay. But I still don't think he's in. Okay. Keep this up so I can let him in. Did he say anything about being kicked off again? Oh no, here it comes. All right, taking a minute. Okay. So no questions about Monday's lecture. Okay. Let's go ahead and I think I'm going to get this going. Okay. So talking about the periodontium consists of the cementum, the alveolar process. So the cementum is the material that is on the outside of the root. So the crown has enamel, dentin, and then the pulp. And then the root has cementum, dentin, and then the pulp. And the cementum is much thinner than the enamel on the crown of the teeth. It's not as hard as the enamel on the crown of the teeth either, so it can easily be damaged. We as hygienists can damage the cementum by being too heavy-handed in the root area. You will learn, like I said, little things that you're going to learn here in this course, you're going to turn around and learn more about in process of care and then instrumentation. So it's just a growing, just constantly growing. So the second part of the periodontium is the alveolar process. The alveolar process is the actual bone that the teeth sit in. And you can see in this image here, this is the periodontium. This purple line is your cementum, so it outlines the root. You have your alveolar process, which is the bone that surrounds the teeth. And then you have your periodontal ligaments that attach from the cementum to the bone via some fibers that we'll talk about here. So the periodontium consists of both supporting soft and hard dental tissue, and it's between the tooth and the alveolar process, as well as parts of the tooth and the alveolar process. So that is the periodontium. It serves as a support system and is an ongoing relationship. And I already said all that. All right, so let's go ahead and talk about the cementum. So the cementum is the part of the periodontium that attaches the teeth to the alveolar bone by anchoring the periodontal ligament, okay? And you can see that these purple fibers, these are called the periodontal ligament, and they attach to the cementum and then attach to other structures. They go around in the gingiva, around the tooth. They go from the cementum to the gingival margin. They go from the cementum to the alveolar crust of the alveolar bone. And then, you know, they do, attaching to the bone, they do almost all the way down the tooth, as you could see in that last picture here. You can see that they have, there's oblique, there's horizontal, there's apical, there's interradicular, there's all kinds, and we'll get there. But so the cementum is what helps to, it's used as an anchor via the PDL, the periodontal ligaments, to the bone to keep the teeth in the bone. It is the outermost layer of the root is your cementum. So it is equivalent to the enamel, but just not as hard, like I said. This is the cemento-enamel junction, also known as the CEJ. Let me see if this picture, the CEJ is this area right here where the cementum and the enamel touch, that little spot right there. Everybody see that? And on this tooth, it's going to be right here. It's also, remember when we were talking the other day about the free gingiva, and they had that free gingival groove, and it almost lines up parallel with that epithelial attachment or that junctional epithelium. It's that junctional epithelium is usually right where the CEJ is. Any questions about this so far? No? Okay. So cementum is the outermost portion of the root. And the CEJ is the area where the cementum and the enamel touch. It is usually covered by the marginal gingiva, but it is, unless there's recession, and then you can see it. The cementum is a hard tissue that is thickest at the root's apex. So it's thicker down here at the apex rather than up here near the CEJ. And in the interradicular areas, so you can see here in between the roots is what interradicular means, of multi-rooted tooth, and it is thinnest at the CEJ near the cervix of the tooth. And what does CEJ stand for? Does anybody want to tell me?
Cemento-enamel junction.
Yes, thank you. All right. Unlike bone, now this is the question you'll hear now and you'll hear it again later. Unlike bone, cementum has no nerve supply and is avascular. So if a person, think about this, if a person has recession, it's probably because that cementum is gone. And so therefore the dentinal tubules in the roots are what are exposed, and that's why they end up with hypersensitivity. So there's no nerve and no blood supply to the cementum. It receives its nutrients through its own embedded cells from the surrounding vascular periodontal ligaments. Like other dental hard tissues, like both the dentin and the alveolar process, cementum can form throughout the lifetime of the tooth, including after eruption. So it does continue to help form, but it does continue to form, but it doesn't, it's almost like once it's removed though, it doesn't grow back. All right. By weight, a mature cementum is 65% inorganic or mineralized material. 23% organic, and 12% water. Here's the beautiful calcium hydroxyapatite, the crystalline formula for cementum. Here are all of the hard tissues. This is table 6 too, so it is in chapter 6, but it really does discuss like where the embryologic background comes from, the type of tissue, whether it's epithelial, connective, the formative tissue, what's formed, ameloblast forms enamel, odontoblast is dentin, cementoblast is the cementum, and the, just want to make sure I know, and the alveolar process is the osteoblasts. So this, like I said, this table is really good, kind of gives a breakdown of it. So I would write a note to go back and take a look at this, because it's a great to be able to line up knowing what everything is, right? All right. So more of the properties of, because of the mineral level, and what did we say the mineral level was 65%, and what is enamel? Enamel is like 96%, so, or 92%. So you can see from this image right here that the cementum appears to be more radiolucent than our enamel, which is very radioopaque. So that's a good point to make about properties there. Clinical considerations in certain situations when cementum is initially exposed from the gingival recession, such as occurring during periodontal disease. It is a pale yellow, lighter than dentin, but darker than the enamel's whitish shade. When instruments are used against its surface, the exposed cementum feels grainy compared to the harder dentin and the even harder, smoother enamel surface. So when you do feel the cementum with your tactile sense with an Explorer, which you will get to at some point, it will feel a little rougher. But remember, the first probably, well, in 190, in 105 and in 191, you're going to be working with your partner patient or with student partners. And many of the students who are going into dental hygiene don't have periodontal disease. So you're not going to see anything more than a healthy pocket. Does everybody understand that? You won't see that until like your 200 or 300 levels. Okay, we start you off easy and then we build you up. All right, cemental caries. This is a chronic condition that forms a large, shallow lesion that slowly invades first the dentin and then the pulp. So these look more like class 5 caries, not your cervical caries. Cervical caries usually are right past the CEJ, whereas I feel like this is not all the way past the CEJ. So, but it's up near the gum line like that. So, cemental caries, I feel like these could also be called root caries. That's the incidence is with people that are older and they end up with that gingival recession or recession due to trauma, because remember, occlusal trauma can cause recession as well. Dental pain is usually a late finding with many of these lesions. You can usually, you will see it usually before they end up having pain with it, because remember, as you get older, your pulp chambers get more narrow. And then the causes are xerostomia, which is dry mouth, poor dexterity, so not angling that toothbrush towards the gum line, not having adequate home care, poor nutrition, eating like crackers and fermentable carbohydrates will really increase your risk of root caries like that. All right. Let's see. Periodontal concerns. Increased controversy surrounds treatment of periodontal disease that involves the removal of the outer layer of cementum during root scaling. root scaling performed during non-surgical periodontal therapy. What happens is, because the cemental surface is very rough microscopically, if you have a periodontal pocket, the pathogens get in underneath the gum and adhere to those rough areas. So think about like, I'm trying to think how to describe that. Like say you have little holes because it's microscopic, and then the tartar bonds, or the calculus bonds your crevicular fluid increases, which has minerals. You have your saliva that gets in your, like you have salivary glands in there that have minerals, and then it hardens underneath your gums, right? So then you have to get down there and remove it from the cemental surface. Well, when it's attached like that, if you don't use the proper stroke, you can end up like popping off the entire cementum, which is not a good thing, right? Our goal is to remove those bacterial toxins and not to damage the cementum in the process. That's why long, slow strokes are really necessary when we're doing root cleaning. But again, that is something down the road. Biofilm and related hardened calculus are associated with the cemental surface of the root deep inside an active periodontal pocket. And then calculus. This is all calculus here. You can see that this is the cementum, and it's kind of, I mean, this is like a real microscopic. This is like really deep. Biofilm and plaque, which is the P. So it builds, right? So the way that tartar is, or calculus is developed, is it bonds to a rough surface, okay? And so when it bonds to that surface, your saliva and things wash across it, and it hardens due to the minerals in our saliva. So then it's microscopic and rough. So then more toxins come in, and then you're ulcerating your gingiva, and all these problems are occurring. The calculus builds up over time. It's like it's like you're scooping sand and rushing it across, and it's just kind of building and building and building, because it gets into those little surfaces. Like you wait for it to harden, and then you put a little bit more, and then it hardens some more, kind of. Am I making sense? Kind of builds. Any questions? Okay. Here's a great picture of calculus on a tooth right here. That would be a fun thing to remove right there. So, periodontal concerns. Let's see, I'm going through all of them. Okay. Now it is believed that these toxins are loosely adherent to the cementum, and that the cementum does not need to be mechanically removed. So when I was in school, they taught us, and this was a long time ago, but they taught us for you to have a very smooth root surface. And over the course of my 15 plus years in clinical, it has changed to where, wait. If it's smooth and glassy, you're removing it all. So we need to be better about not removing that the cementum, with the calculus. Root scaling performed during non-surgical periodontal therapy is only to be used to remove the hardened calculus, not to make it glossy smooth like I was taught in school. So, all right, any questions about that? What goes on in the periodontium or anything like that? Or in the, okay. All right, on to the cementum development. All right, so it develops in a dental sac. Remember, we learned that before. It forms on the root dentin after the disintegration of the Hurwitz epithelial root sheath. Remember that epithelial root sheath kind of starts to, the outer and the inner epithelial cells come together, and they form that root, the down here. So here are your odontoblasts, which are forming the tooth. Here's your predentin, right? And then you have your cementocytes, these little black dots. You have your cementum, which is right here. Your cementoblasts are these little things. And then your dental sac is this big pink part, which they are trying to form. This disintegration allows the undifferentiated cells of the dental sac to come in contact with the newly formed surface of the root dentin, introducing these cells to become cementoblasts. So the Hurwitz epithelial root sheath starts to form. It's not in here, but it differentiates, and then once it disintegrates, it starts to differentiate and starts to form the root dentin. All right, cementoblasts then disperse to cover the root dentin area and undergo cementogenesis, or the laying down of cementum, right? Cementoid. Unlike ameloblast and odontoblasts, which leave no cellular bodies in the secreted products during the latter step within the appositional stage, many of the cementoblasts become entrapped by the cementum they produce, becoming cementocytes. All right, so we talked about those periodontal ligaments, and we're going to kind of touch on what goes on in the cementum there. The cementum is composed of mineralized fibrous matrix and cells. The Sharpie fibers, highlight this in your book. Sharpie fibers are collagen fibers from the periodontal ligament that are partially inserted into the outer surface of the cementum at a 90-degree angle or perpendicular. So you can see that they have little Sharpie fibers here, and they're these little fibers that go into the cementum to they're collagen fibers that kind of hold on to the fibers, so that to the periodontal ligament, so that they hold on to the cementum, and then they hold on to the bone. So they're on both sides. They're these little lines here, and then these little lines that go into the bone. They are inserted on the other end into the alveolar process at the same angulation. So Sharpie's fibers are inserted at the cementum and the alveolar process at a 90-degree angle. Any questions about Sharpie's fibers? All right. So the cells of the cementum are the entrapped cementoblasts and cementocytes, or entrapped cementoblast, the cementocytes. Each cementocyte lies in a leucana, or a leucane, which is similar to the pattern noted in the bone. They also have caniculi or canals. So there's little, if you remember from this little picture, not there, here. There's the cementocyte, then there's cementoblast, and they make the cementum there. But unlike those in bone, the canals in cementum do not contain nerves, nor do they radiate outward. Instead, the canals are oriented toward the PDL and contain cementocytic processes that exist to diffuse nutrients from the vascularized periodontal ligament. However, cementocytes in deeper layers may no longer be vital. So, all right, so here is your microscopic section of the cellular cementum. Here is your cellular cementum in here, and then your periodontal ligament is here. All right, so let's talk about, so here's something that I think that you should know about the cementum histology and the CEJ. The CEJ can either be overlapping, they can meet, or there can be a gap. So you can see in this picture here, and I'm going to try to blow this up for you a little bit. Nope. There we go. You can see here that this would be an overlap. So your cementum is overlapping the enamel, okay? Here, it's where they meet. It's just like a millimeter that they overlap one another. And then the gap is where they don't touch at all. What do you think would happen? Who would like to tell me, what do you think could happen in a situation like this? How do you?
Get perforated or like damaged in that area because it's weaker?
Yes, but let me try to think how I should phrase this. What could a patient have a symptom of with that gap being there?
Sensitivity.
Yes, thank you. Good job. Yes, they could have dentinal hypersensitivity. All right. Nope. Talked about that already. All right. Two different types of cementum. There's acellular cementum and then there's cellular cementum. And they're both formed by the cementoblast. Acellular cementum consists of the first layers of cementum deposited at the dentinocemental junction. And this is also known as your primary cementum. It is formed at a slower rate than others and contains no embedded cementocytes. At least one layer of acellular cementum covers the entire outer surface of each root, with many more layers covering the cervical 1/3 of the near the CEJ. So cervical 1/3 would be closest to the CEJ line. All right, here's your acellular. First layer is deposited, at least one layer over an entire root, formed at a slower rate, no embedded cementocytes with constant over time. Cellular is formed after the acellular layer, okay? And it's layered over the acellular layer and is mostly in the apical 1/3, whereas the other one is in the cervical. Apical 1/3, and then it's formed at a faster rate. It has embedded cementocytes and can widen over time, so layers can be added. So you don't get so much of that near the CEJ, but you do get it down at the apex. Any questions about acellular and cellular cementum? All right, so like I said, it's secondary. I already talked about all this. I don't need to go over that again. All right, there's this same thing I just discussed. All right, cementum repair. Similar to bone tissue, such as the alveolar process, cementum can undergo removal within the tissue as a result of trauma. This removal involves resorption of cementum by the odontoclast, resulting in reversal lines. When viewed in a microscopic section of cementum, these reversal lines appear as scallop lines, just as in bone. At the same time, there can be repair of traumatic resorption areas by involving the appositional growth of cementum by the cementoblast in the adjacent PDL. Appositional growth of this recently formed protective cementum is noted by the arrest lines. These arrest lines, when viewed in a microscopic, look like smooth growth rings. So here you go. So the reversal lines and then the arrest lines in cementum with embedded cementocytes, that would be the white lines, right? So your embedded cementocytes and then your reversal lines and arrest line. And then your black lines, these are things that may have undergone trauma. On the surface of cementum are the cementoblasts, which are the the dark arrows, within the surrounding periodontal ligament, which is here. This is the PDL, this is the alveolar bone proper. So, and you can see that it has similar notes of remodeling. So like you can have like where it starts to repair, but it's going to lay slightly different, and there's going to be lines for it. All right. Cementosicles are one clinical consideration, and they are mineralized spherical bodies of cementum found either attached to the cemental root surface, which is like the one right here, or lying free in the periodontal ligament. They form from an appositional growth of cementum around the cellular debris in the PDL as a result of microtrauma to a Sharpie's fiber. Cemental spurs can be found at or near the CEJ. These are symmetrical spheres of cementum attached to the cemental root surface, similar to an enamel pearl. These spurs can result from irregular depositing of cementum on the root and may be noted on radiographs. So there's not a picture of that in this is hypercementosis. Hypercementosis is the excessive production of cellular cementum, which mostly occurs at the apex or the apices. And you can see here, you can see that darker red line is the cementum, and you can see it's kind of an overgrowth there. And then here it is right here. So it's growing more, so it becomes more radioopaque. It may present on a radiograph as a radioopaque mass near the root apex. And then there's root apex resorption, and this is where the apex of the root starts to dissolve and reduces in length, overall length of the tooth, which is especially noted on these anteriors. And it can be caused from like fast movement of the teeth, things like that. During orthodontics. This is concrescence. This is excessive cementum formation that may occur, and it kind of bonds a bunch of teeth together. So, this was one of the, so concrescence is one of the overgrowth of cementum. It's a developmental disturbance as well. Okay. Any questions about, let's see. Close out of here real quick. Okay. And stop sharing. Okay. So any questions about cementum or like of the periodontium? Miss, let's see. Sam. Yeah. Sam, can you tell me what cementum is? Or where it covers?
Are you talking to me?
Yeah.
Oh, sorry.
What
It's
does
a-
cementum cover? Yeah.
It's a hard tissue that is thickest at the tooth's apex.
Okay. And but what part of the tooth does it cover? Miss Jeanette, do you want to help Miss Sam out?
Isn't it the root surface?
Yes, it covers the root. Thank you, Jeanette. Okay, so yeah, it covers the root surface. So it's the protection under the root. And where's my mouse going? Okay. There it is. Oh, okay. Put that there. What makes, Courtney, can you tell me what makes the cementum?
So are we talking about the cells, like the cementoblasts and the
Yes.
cematocytes? Okay.
Yep, the cementoblast. Yes, that's what I'm looking for. Okay. What are the Miss Shelby? What are the name of the fibers that hold the periodontal ligaments to the cementum and the alveolar bone?
The Sharpie fibers.
Good job. And Natalia, can you tell me what angle those are in the bone and in the cementum? At what angle?
I'm not really sure.
Okay, Miss Mary Beth.
A 90-degree angle or
Thank you very
perpendicular.
much. Perfect. Okay. All right. Well, I think you guys got the cementum part that you need to know down. That's good. All right. So now we are going to go ahead and move on to the alveolar process. So let me, so, you know, my computers are here and here. So I look at you, you guys are down here. So if you do have I'm looking here when I'm talking to you. So if you guys do have a question, please just speak up. This isn't, we are not in a form, like this is already hard for me. So make it a little easy, just speak up.
I have a question about the Sharpie fiber.
Yeah, sure, go ahead.
Are they just it's just the attachment, it's not the whole fiber. It's just
No,
attaches.
each periodontal ligament has a different name. So it's like an actual like ligament, but it is attached to so like the ligament kind of goes into the Sharpie fiber, and then the Sharpie fiber's in the cementum or the bone.
Got it.
Understood? Okay, cool. All right. Let's see. I don't know that nope. Okay. Everybody can see this. Okay. All right, so the alveolar process. Ms. Filbert, do you want to tell me what the alveolar process is before? Do you know what you know about the alveolar process? I said it at the beginning of class. This isn't supposed to stump you guys.
Is it the parts of the bones that hold the teeth in place?
That's all I'm looking for. Thank you so much. All right. Okay, so the alveolar process properties. All right, so the alveolar process is that the part that either in the maxilla or the mandible that supports and protects the teeth. It is different type of bone than that of the mandible or the maxilla. It is and we'll kind of talk about that in just a minute. It's a different type of bone than that cortical. I think it's a cortical bone that is in our jaw. Or maybe the cortical is the process. We'll get there. We'll get there. All right. The alveolar process is also, okay, wait, hold on. I have a question. I have a chat. If you notice my camera off in here. Oh, I'm trying to type and this isn't. All right. Let's see. I can go back now. Boop. All right. The alveolar process is also that part of the periodontium in which the cementum of the tooth is attached to it by way of the periodontal ligament. So your alveolar crest, which is this part right here, this crestal bone is right. It is very, very close. I mean, you can see how close that is. It's slightly like below where that attached gingiva happens. So when you're looking at a radiograph, if that bone isn't rounded like that and isn't close to that CEJ like that, we're starting to look at some bone loss in that area, right? Even if it's just crestal, it's there. That the term alveolar process will be used mostly since it it has a clinical connotation, whereas the other term that could be used is the alveolar bone is more of a histological background. So we'll call this the alveolar process. It is a hard mineralized tissue that have all the components of other bone. Like bone, the mature alveolar process is by weight 60% inorganic or mineralized material, 25 organic, and 15 water. There is the crystalline formation for it, the chemical formula for bone. Again, this table comes in. The alveolar process, which is over on the far right, is made, the embryologic background is from the dental sac. Sometimes I have to slow down. It's the tissue source is the connective tissue. It is formed by osteoblasts. Incremental lines are arrest or reversal lines, very similar to the cementum. The mature cells are osteocytes. Resorptive cells are your osteoclasts. Again, 60% inorganic, 25 organic, and 15 water. It is possible for regeneration after eruption. Vascularity is present and it's innervated by the nerves. All right, so jaw development. Both the maxilla and the mandible are developed by the first pharyngeal branches, right? We've already been tested on that. We can move on from that part. The maxilla forms within the maxillary process. The mandibular forms within the mandibular process of the mandibular arch. And both jaws also start as small centers of intramembranous ossification located around the stomadeum. All right. We already talked about all this. Okay, so let's talk a little bit about this part. The mandible subsequently develops as several skeletal units. This is just the mandible. The condylar unit that forms the articulation with the temporal bone, the body of the mandible, which is the center of all growth of the mandible. Excuse me, the angular unit, which forms in response to the lateral pterygoid and the masseter muscles. The coronoid unit, which forms in response to the temporalis muscle development, and then the alveolar unit, which is, forms in the response to the mandibular teeth. We've already talked about these during jaw development. Some clinical considerations are anodontia, which is partially missing or partially missing teeth, dentition. Jaw anatomy and histology. So each mature jawbone is composed of two types of bone with differing physiological functions. And here from last term, here's your ramus, your angle of the mandible, your neck, your condyle, your mandibular arch, your coronoid process, coronoid notch, your body. And then your body of the maxilla is up here. And then here is your maxillary tuberosity. This is your alveolar process. You can see where this dotted line is. That's your alveolar process of the mandible. Dotted line here, this is your alveolar process of the maxilla. Everybody see that? Okay. The part that contains the root of the teeth is the alveolar process, which is referred to as the alveolar bone or also as the alveolar ridge. The part apical to the roots of the teeth is called the basal bone, which then forms into the body of the mandible, thus is not part of the periodontium. So the very apical part after the roots is the basal bone, and then it goes into the body of the the body of the maxilla or the body of the mandible. All right, so you can see it's kind of like this ridge right here. You can almost see in this picture the different type of bone. Let me blow this up for you. Okay, good. You can see that this bone is very solid, and this one is more trabeculated. So it's a trabecular bone, whereas this is that thicker bone. And you can see radiographically when you see a radiograph where it almost looks like there's little canals in it, whereas then there's like that dark radio opaque. Let me see if I have a radiograph. Just gonna flip through, see if I have one. There, right here. Okay, kind of, but we'll go here. You can see how this is almost like kind of see-through in a way. Does everybody see what I'm talking about? And then this is like your dark, it starts to get a little more radio opaque, more like condensed. Yeah, okay.
Question, please.
I'm sorry, go ahead.
Question. Yeah, so these, it looks like the two bones, one is kind of like, the one at the bottom is kind of solid compared to where the roots are. Are they composed of different mineral substances?
Yes, and so we're gonna, and they're different types of bone. So, and we're getting into there. I just wanted to make sure you could see what I was talking about. But good question, Ms. Filbert. We'll be back to that. I'll answer you in just a minute. Okay, where was I? Here. So, like I said, you have your alveolar process, which is this bone here, and then you have the your basal bone, which is like this line, and then you have your body of the mandible. All right, microscopically, both the alveolar bone proper and the supporting alveolar bone have the same components: fiber cells, intercellular substances, nerves, blood vessels, and lymphatics. But the arrangement of these components is different. So let's see, yeah. The alveolar bone proper is the lining of the tooth socket or the alveoli. Although the alveolar bone proper is composed of compact bone, it may be referred to as a cribriform plate because it contains numerous holes where Volkmann canals with its nerves and blood vessels pass from the alveolar bone process to the PDL. Someone was really excited about writing pass. I should have read it like that. So the bone, like on the cheek side, is much thinner, or like the buccal and lingual, than it is kind of in the middle, because of the fact that like although it's made of compact bone, it's a thin, like it's got all those holes in it, like it says, but on the lingual and the buccal, it can be sometimes thinner, which is why a certain amount of tilting of the teeth facially or lingually could sometimes cause what seems to be recession, and is recession, but it's bone loss because it just doesn't have that thick bone. It's not a very thick bone for it to be covering that area. Does that make sense? Like it can, if a tooth is tilted a certain way, you could end up having bone loss because of the fact that it's like it's in the way. The bone is like in the way. All right, so the alveolar bone process is also considered bundle bone because Sharpey's fibers, as a part of the fibers of the periodontal ligament, are inserted there. Similar to those of the cemental surface, Sharpey's fibers in the alveolar bone process are each inserted at a 90-degree angle or perpendicular to the alveolar process to mediate the anchorage of the tooth. All right, so let's talk some more about the alveoli, which are the tooth sockets. So in that other picture where the teeth were out, you could see where the teeth would have sat in. So the tooth sockets of the alveolar process of each of both the maxilla, of each of the maxilla are usually, because there's two parts, are usually 8 in number and vary in size and depth according to the teeth they contain. Next week, we'll get into the numbers, but there are 8 on each side of the maxilla. The canines have the deepest alveoli because they have the longest root. Those of the molar are the widest, usually because of the fact that they have a root trunk and then they have multiple roots, and are subdivided into minor cavities by septa. So the septa is that it would be in between the two roots, right? And those for the incisors are single but deep and narrow. All right. So the alveolar bone consists of plates of compact bone that surround the teeth and assume the shape of the tooth. The ABP varies in thickness from 0.1 to 0.5 millimeters. So like imagine if that, being that it's maybe if it's only 0.1 millimeters here on the facials and you have a slight tilt in your teeth, it's going to like recede a little bit is what I was trying to say earlier. But the part of the alveolar bone proper that is present in radiographs is the lamina dura, which is a uniformly opaque, radio-opaque, or it's lighter. So you can see, like here's your alveolar crest right up here. Here's your alveolar bone proper here. And then your lamina dura is kind of this dark, this white radio opaque that goes all the way around the teeth. You can see it here too. Do you guys see that? You see what I'm talking about? Okay. The alveolar crest, which is what that would be, here's an outline of the way the crest should be because of the fact it's that most cervical rim. So let me go back here. Here is your alveolar crest, okay? In a healthy situation, the alveolar crest is slightly apical, and that's what I was saying, like if you look where the CEJ is, that alveolar bone proper is going to, or the crest is going to be approximately 1 to 2 millimeters apical, so towards the root tip from the CEJ. The alveolar crest of neighboring teeth are also uniform in height along the jaw of a healthy jaw. So like if you have, you can totally have generalized horizontal bone loss to where you start to see a flattening out of that alveolar crest in between all the teeth. So, any questions so far about the alveolar bone proper? Okay. All right, so now for the periodontal properties of, let's see, where am I? Because I like to follow. Okay. All right. So here again, this is just the properties of the periodontium. Our enamel, there's our dentin, here's our cementum in dark purple, our cementoblasts on the outside, our cementocytes that are inside the cementum are in here. These are our periodontal ligaments, which we will talk more about in just, towards the end of this class, this lecture. This is your lamina propria of the gingival margin, your junctional epithelium, your alveolar crest right here, okay? Sharpie fibers, don't forget, are your little, they go in there, okay? All right, so the part of the alveolar crest that is in between neighboring teeth is the interdental septum. So on a bite wing, it would be what would be in between the teeth, okay? So that would be your interdental septum or your interdental bone, okay? Your supporting alveolar bone consists of both cortical bone and trabecular bone. Your cortical bone consists of a plate of compact bone on both the facial and the lingual surfaces of the alveolar process. Thus, the term cortical plate is also used to describe the part of the alveolar process. All right. So your cortical bone will be here on your, I mean, and you can see that that cortical bone is thinner than, you know, this bone down here, or even in the middle here. And this is called your interdental septum, the bone in between your teeth. And then the in between two roots or three roots is your interradicular septum, but we'll get into that in a minute, I think. Cortical bone is not visible on a periapical or a bite wing because of the fact that it's, you know, a two-dimensional, and you can't really, I mean, if you took a CT scan, you could, but radiograph, and it's usually just, it looks like a bony sheet. So it's uniformly radio-opaque on the facial and lingual teeth. Trabecular bone consists of cancellous bone or spongy bone that is located, so real quick, your cortical plate bone is what type of bone?
Compact.
Yes, good. So then your trabecular bone is what type?
Spongy.
Yep, or cancellous, good job. That is located between the alveolar bone proper and the plates of the cortical bone. Only the parts of the trabecular bone between the teeth and between the roots are ever present on a radiograph. So when you see that bone in between the teeth, that's trabecular bone. Whereas that cortical bone, we don't always see because of the fact it's only coming this way. We never get to see the distal or the lingual or the facial. This trabecular bone appears less uniformly radio-opaque and more porous than the radio-opaque lamina dura and that's that darker, that whiter area in between the teeth or around the root. So,
Question, please.
Yes, go ahead.
So is it the crest we are seeing right here? Is it part of the
It's
cortical
part
bone?
of the trabecular.
Trabecular bone.
Mhm.
So that's the
This is-
crest we see.
This is all trabecular and this is the alveolar crest. Yes.
Okay.
Yeah. What we can't see is the bone that is covering this part right here, like this part. We can see the interradicular, the interradicular septum here, which we're going to talk about in a minute, but we can't see the cortical bone from where we're with this radiograph. Let's finish these slides and I'll let you guys take a break and I'll pull up a picture where you can see a CT scan and you'll be able to see the cortical bone. Okay, so give me just a minute. I have one because I totally took a picture of it on Instagram the other day because I thought it was cool. The alveolar process that separates the two neighboring teeth is the interdental septum, like I said, and then your interradicular septum is in between. It is present on both periapical and bite wings because you can see it, it's right there. And this interdental septum is what type of bone?
Is it intraradical?
No, it's interdental septum is in between, but what kind of bone is it? Is it cortical or trabecular?
Trabecular.
Thank you, ma'am. I knew y'all knew it. I just needed somebody to say it. Okay. The alveolar process that separates the roots are the interradicular septum or the interradicular bone. Only a part of the interradicular septum is ever present on the periapical or the bite wing. So, like I was saying, this is the part of, so you can only see this part of it, the part that's in between the two roots. You can't see what's on the front. You know what I mean? Like you can't see the front portion. Does everybody understand what I'm saying? Okay. If I go back, let me see. I'll go back to where, like you can't see these areas, but you can see all in between the teeth. Does this help it make, yeah? You can see it in between, like you can see this in the radiograph, but you can never see this part. You can see this part in between, but you can never see this part unless it's a beam that comes from this way. That way you can get, but you can't really get an x-ray from that side unless it's
So-
a CT scan.
If you use a cone beam, can you see that?
Yeah, CT scan, cone beam, yes, yes. For those of you who know what a cone beam is, yes, you can see it with a cone beam, but that's the only way you can see it. And that's what I'll pull up at the break and I'll try to show you guys. Okay. Moving on, ta-ta. Okay, clinical considerations with dental procedures and pathology involving the alveolar process, orthodontic therapy. We are moving the teeth using compression and pulling of the periodontal ligaments, right? So the bone remodeling can be forced with orthodontic therapy to produce tooth movement or repositioning. Bands and wires or appliances put pressure on one side of the tooth. So the periodontal ligament is pulled from one side but compressed on the other to get, so there's the pulling pushes on the bone over here and forces the bone to resorb a little bit, so then it can be pulled along, the other bone can be pulled along, like so. So here's your compression zone and your tension zone. This is a, I had the word on the tip of my tongue and now I've lost it. This is an immune response. Okay, so this is something that like we, an inflammatory response. That's the word I'm looking for. Sorry. Inflammatory response. So we want there to be that inflammation of the pulling and the pushing to put our teeth, to line our teeth up where we want to be. One of the things you'll hear dentists say a lot, and it drives me nuts, is go ahead and take some Motrin for orthodontic pain. What Motrin does, it's a NSAID drug, so it's a non-steroidal anti-inflammatory. So what it does is it blocks the inflammatory process from happening. So what we should be telling our patients is not to use NSAIDs for orthodontic treatment, but to just use a painkiller like Tylenol or acetaminophen, because it does not have the anti-inflammatory response. That's just a side note. For anybody who might have kids that are in braces, don't give them Motrin. You want them to heal properly. It delays the healing process because you want that inflammation of pulling and pushing. I mean, that's what you're paying the orthodontist for, right? And so if you inhibit that, it's going to, and you want it to be done slowly, and that's why they have to put that tension and everything like that. But it's a very neat process, but it does, you are, the compression zone is resorbing bone, whereas the tension zone is depositing the osteoblast to form more bone. Just like if you have a tooth extracted, you build bone back in. Sometimes if you're getting an implant, they'll go ahead and put bone in there to kind of help that process speed up a little bit. But for the most part, if you just take a tooth out over time, it's going to fill in with bone. It may not be the right level or the right height, but it does normally fill in with bone. Mesial drift. This is the natural movement phenomenon in the oral cavity. This happens, I mean, gravity, right? Everything pulls everything forward. As we get older, our noses get longer, our ears get longer. Our jaws, we start to get this mesial drift of our teeth and we get crowding in our anteriors, even though it was never like that before, but it starts progressively over time as we get older. So this is just something that is, our teeth are constantly in passive eruption. They're constantly moving. First of all, it's like they have memory. They want to go back to where they were. That's why orthodontists put wires behind your front teeth and wires, and make you wear a retainer till you're 40 years old. And then but if you don't do any of, then you end up with this crowding and things like that. This is a very yummy looking mouth right here. I'd love to get a Cavitron on that one, but can't because it's a picture. Over eruption or super eruption, you can see from this this image here that number 3 has been extracted. So because of that, the other teeth have tilted in a direction, causing poor occlusion in these areas. You can end up with fractures because of the fact that they're not lined up correctly. And we'll learn a lot more about this in the last week of class, because we'll talk about occlusion. But you can see that because of that, this tooth has kind of started to come up out of that occlusal plane line, or these have been pushed down. Likewise, on the top, if you have a bottom tooth, it really will continue to fall until it occludes with something. So if our teeth stop eruption when we get into that occlusion, if we are out of occlusion, our teeth will just continue to erupt, basically. There's nothing to occlude with. It just thinks that it needs to keep coming. So what do you think? Yes, go ahead.
So does this process take place during the movement of the jaws, like during speaking, during eating, or
During
of that
all day
nature?
long, just all day.
Wow.
It's just a constant process, yeah.
So over time, like I see this, I don't know if it's number 3, but this maxillary.
Yep, this one right here, the one I'm
molar-
circling.
No, on the other picture, 17.56. Yeah,
this
that
one-
doesn't have a bottom to it. Is it like it's going to keep drifting down?
Well,
And-
not necessarily here, because of the fact that it's occluding here and here, and it's touching these two teeth. But say this tooth stayed upright, okay? And it didn't tilt like it's doing. Say it stood upright. This one would keep coming until it hit something else. And what do you think could be the result of that in the CEJ area? What do you think could happen if that tooth continues to erupt or super erupt?
Eventually, the cementum would be exposed, wouldn't it?
Right. And what is that called? Mr. Hojan, what is that called? I can't hear you because you're muted.
Is it cement or something caries?
Go ahead.
I don't know the full name. I just know this. Is it the caries is it the caries that happens in a cementum? I don't know.
It could eventually, but what is the first thing? So when that tooth continues to erupt, that tissue, even if it stays the same level at a healthy level, but that tooth continues to erupt, and the cementum is going to show. What is that called? Does anybody know?
Would it be recession?
Yes, it would be recession. Good job. Okay. I'm just trying to make you guys think, sorry. Now I'm starting to get comfortable with you, so whoops. Like Mrs. Calhoun before she started asking a bunch of questions. Over eruption is a physiologic movement of the teeth lacking an opposition partner. Like I said, if the exposure of the root surface could cause dental hypersensitivity, root caries, create an aesthetic compromise, as well as compromise the tooth's periodontal health. Because if that tooth starts to continue to erupt, you're going to end up with the furcation. And we haven't gotten to tooth morphology yet, but you have been drawing, and when the root splits, that's called the furcation. And if that starts to become exposed, it opens up a whole new, you can get caries in that area, you can get fractures in those areas. It just opens up, it compromises your periodontal health. So, edentulosum. After extraction of a tooth, the clot of the alveolus fills with primary bone, which later is remodeled into mature secondary bone. Remember, like I said, but it never really forms back because it doesn't have the teeth to surround. It ends up being partially complete, And you can kind of see where it just kind of like dips down. It's not like a nice smooth, like how you picture like the teeth in your mouth, you know, nice smooth. It kind of dips down. It never grows in, you know, properly. And over time, if you have dentures can sit there and continually, constantly wear on that bone and hit that bone, and sometimes be traumatic if you don't get them fitted properly. And like people think that if they get dentures, they never have to go to the dentist again. But if you don't go, then you don't have the chance of keeping that the denture healthy to your tissue, like your tissue healthy and the denture to fit properly. Like, so if you have high spots, it's like, I've made this comment several times. I don't know if I've made it to you, but it's like sitting at a cafeteria lunch table in school, and the really, really, really annoying kid comes and sits at your table, and slowly but surely people start to move away until like there's like nobody there. Your bone is the same way. Like, it doesn't want to be nagged on by the calculus. It doesn't want to be hit on by the denture. It just wants to be like kind of happy. And so that's the way I explain it to my patients when I'm cleaning their pockets and I'm cleaning all the disease out. And I'm like, well, why is my bone going away? I'm like, because nobody wants to sit next to the annoying kid at the table. They all want to, you know, just kind of live.
I have a question.
Sure.
So I guess I'm not understanding the difference between edonculus and edontia, because
They're the same.
Okay.
Edentulous
I've always
is,
heard this term and
yeah.
not edontia.
So anodontia is missing teeth. Like, you never grow them in.
Okay.
It's
But
a
this is like
developmental
you had
issue.
teeth and then now they're gone.
This is because I don't know. Like, you just did not take care of your mouth. It's that this is the law, the removal of the teeth due to disease, or trauma, right? Not the same. So edentulous had their teeth, but now they're gone. Anodontia is never really had the teeth to begin with. Okay. And I kind of mentioned the other day, like the vertical dementia, like as we age, we start to get, you know, we just kind of shrink. I don't know where Mrs. Calhoun's going to go. She's just going to keep getting tinier. But you lose this. And I said this the other day when, was it Alicia? No. Yes, Alicia, it was during your presentation, right? Who did anodontia? Was it, nope, it was Brittany and Filbert. The kid from Stranger Things, and he's anodontia, so he's missing teeth. And so you can almost tell in the structure of his face, it just kind of like sags a little bit. It's different. And you can kind of see that here, like the you know, this is like the teeth are kind of, I don't know why they even have the picture of the teeth in here. They should have one with no teeth so you could see the fact that like teeth give you that maximum like width of the bone, the teeth and everything. And as you lose that bone, as you lose teeth, you start to like drop down where like, you know, you can, and you'll start to see it everywhere you go. Like you'll look and you'll be in Target and you'll be like, that person doesn't have any teeth and that person doesn't have, like, because you start to notice these things. You start to look at facial structure, like the sag. I mean, and it's not just age, it's like this, the way they carry their mouth. I think somebody made the comment about that the other day when we were talking about the kid from Stranger Things and how like, yes, he doesn't wear his dentures during filming, or, you know, so you can definitely tell that there was something going on, but you didn't realize that that's what it was, right? So, but we start to lose, you know, they start to lose that bone, and you start to, your vertical dimension of your face it changes. All right. Yeah, so your golden portions, it's 3 divisions. You have the A, which is from your eyes to, you know, right under your nose, and then you have your maxilla, and then you have your mandible. So imagine if you lost, you know, the size of the teeth, you know, I mean, how many of our teeth are we're drawing teeth, what, like most of them are like 6-7 millimeters long, right? Like the crowns. Like imagine if you lost that on both sides. That's almost, 14 millimeters just gone. So that kind of, I'm touching this like you can see it. You can't see my fingers. This ends up decreasing. Does that make sense? Yes. All right. Implant placement. Ideally, an implant. Let's see. Okay. We're very heavily on the other part, and that's periodontal ligament. Dental implant is placed in an edentulous area. So, and you can see that the bone doesn't come up, as high, but it still gives good, which preserves the integrity of the bone, provides adequate stimulation, and serves as a permanent replacement for a lost tooth. I always say, if you have to have a double root canal, just get the implant. I think it's a much brighter. I mean, and look, you can't even, yes, I know that this is the implant, but you can't really even tell that that's the implant. All right. A basic dental implant is a core part made of titanium that is surgically implanted, and so cool to watch, into the bone of either jaw, and then it's placed with a composite, or you can do, I've seen them, I worked in an implant office in Memphis, Tennessee, and they do these things called all-on-4s, where like an edentulous person would have 4 or 6 implants put in, and then the denture pops onto, especially for the lower arch, if you lose all of them, because your tongue is so strong that it wants to flip it out. I mean, none of y'all are going to have this problem. We're not going to, we're not going to lose all of our teeth on our lower arch, but I'm just saying. But yeah, unlike natural teeth, having an insertion of the principal fiber groups of the PDL into the alveolar process via the Sharpie fibers that allow for movement, the implant cannot be moved. So say you have an implant and then you decide you want to get your teeth lined up, you can't, because that tooth is already there. It's better to do it before than to do it then you can't really do it after. The implant makes direct contact with the alveolar process via osseointegration, as well as with the surrounding connective tissue, and it's more superficial epithelium, making the peri-implant tissue. So implants are really cool. Usually the only time that there's failure is that there's something there that is causing or complete inadequate home care, but most people who I have seen who get implants are really big on taking care of it. All right, periodontitis. This is another problem that can occur. During chronic advanced periodontal disease of periodontitis, the localized alveolar bone is lost at varying levels depending on the length and the amount of the disease involved. You can see in this image here, like this is where the alveolar crest should be, right? And this is where the bone level is. Again, this is really cool, but you won't get to see it until like the end of 200 level, 200, 300 level in class, okay? I mean, just look at you can see the widening of the PDL, like those teeth are probably very loose. You have to hold them and clean them. When periodontitis initially develops or progression, the hard and soft tissue destruction is by both collagen and extracellular matrix degrading. The degradation, yes, is primarily by proteinase, protein degrading enzymes. There are many types of proteinase, including matrix metalloproteinase, MMP. have to take it slow. I can't just like throw it out there because it'll be wrong. All right, assessment of MMP in the tissue of the periodontium, gingival crevicular fluid, or saliva may serve as an important future biomarker in diagnosis of periodontal disease and also for prognostic follow-up. I wish we tested for stuff like this more frequently, but we don't. Periodontists might, but we don't as hygienists. All right, so there you go. There's your, here is your fibrosis. Here's your alveolar bone proper. Here's your periodontal ligament. There's your, this is A. Oh, we're talking about B here. So yeah, this is a close-up of showing the bone resorption. And then from the alveolar bone, due to the osteoclast activity beneath the inflammation of the periodontal ligament. So here's your periodontal ligament. Here's the bone resorption here. Just not good. The bone loss is first evident in the most coronal part of the alveolar bone proper, the alveolar crest, which looks moth-eaten, both microscopically and radiographically. So you can see here in this, like that's where it should be, and this is where it's starting to disintegrate. All right. And here's where you can see this is, I showed this earlier, that's where it should be and then where it is. Mobility is the movement of the teeth due to loss of the periodontium. Obviously with that tooth, they didn't have a lot of, and then there's furcation involvement. So if there's a multi-rooted tooth, you start to get the loss of the interradicular septum of the multi-rooted teeth. And there's classifications of destruction, class 1 through class 4. And so I'm not going to overkill you with that, but that there are 4 different classifications for furcation. Fenestration is when you start to get that cortical bone starts to resorb and gives you like a little window, and you can kind of see, how that it starts to thin out, and you start to see be able to see that buccal surface of the tooth or of the root. All right. Dehiscence is the rim of the bone between the fenestration and the alveolar crest may disappear altogether and produce a defect. So as dehiscence, but it doesn't really, it just means the rim of bone between the fenestration and the alveolar crest. So here, alveolar crest, and I might have to look at that again, how that is considered. Dehiscent all the way up there though, because it's alveolar crest, the fenestration from the alveolar crest disappears altogether, producing a defect. Okay. Here you go. So it must be from that, reveals the structural fragility of the facial bone plate in region of the maxillary incisors, in addition to the dimensional relationship with periodontal space and mineralization of the tooth and mineralized tooth structures. So you start to, so this is a CT scan or a cone beam. And like I was saying, you can see it from, here's your buccal and here's your lingual bone. You wouldn't be able to see that on a radiograph, but you can't really see now you can't see the interproximal bone, right? So, but here is like dehiscence right here. It's where you start to get that fragility of that facial bone at the alveolar crest. And then bone grafting. This is the source from either the alveolar process or other bones, such as a person's chin, and even from other sources as cadavers, and they surgically implant bone tissue into a surgical site. That's it right there. There's the hole, and then they pack it full of bone. And then they sew it up and then it heals just usually pretty fine. Dental infection route, density of the alveolar process in the given area also determines the route that dental infection takes with abscess formation, as well as the efficacy of local infiltration of the agent during the administration of local anesthesia. So if there is an infection, it's not ideal to give local anesthetic. You want to get rid of the infection before you give the local anesthetic, because the two acids, it won't work really well. In addition, the differences in alveolar process density determine the easiest and most convenient areas of bony structures to be used if needed during a tooth extraction or impacted teeth. All right, so that was all we have left now is the periodontal ligaments. Any questions about the alveolar bone proper? Okay, Miss Amanda, what is the bone that is seen, what type of bone is seen facial and lingual on and the alveolar bone proper?
The cortical bone?
Yes. And Miss Tara, what is Tara, excuse me, what is the bone that is in between teeth, the two teeth? I think you froze up. I think everybody froze up. Oh, everybody froze up. I don't know. My internet was unstable for a minute. What did you say,
Is it
Tara?
the trabecular bone?
Trabecular bone, yes. Everybody was frozen. I was too, I'm sure. Or I was just talking and y'all were making fun of me behind my back, and that's fine. That's fine. I don't care. I make fun of myself to myself. I don't need to do it behind my back. And then what is the name of the bone that's apical to or just below the apex? Does anybody remember the name of it?
Is it the
Yes.
basal?
Yes, the basal bone. Okay, good. Let's see. The radio-opaque lines near the roots are called what?
The cementum?
No, it's, those are gonna be not as radio-opaque as this. This is kind of on the other side of the periodontal ligament. It gives you that, so you have your root and then you have like a dark line and then you have another line, you have a radiolucent line and then a radio-opaque line. Radiolucent line would be your periodontal ligament, and then your radio-opaque line would be the
Lamina dura.
lamina dura. Good job. All right, and then what is the area called in between the teeth, bone-wise? Not trabecular, that's a type of bone, it's trabecular bone, but what is it?
The interdental bone?
The interdental bone, and then the bone in between the roots.
Is it the interdental septum?
Interradicular, and you'll need to know that again because it goes on to the periodontal ligament too. So for the different types of fibers that are in there. So, okay. All right. I think, you know, I'm making way here. Why don't we go ahead and take this is not a very long one. Why don't we go ahead and do a 5-minute break and then come back, finish it up, and then we'll be done for the day. Okay. Okay. Yep, I'm back. All right. On to the periodontal or the periodontium. The periodontal ligament. Now, we already know that these are attached to the cementum and to the alveolar bone proper via the Sharpie fibers, right? So that's a first thing we know about these little ligaments. We haven't even, and they're, you know, they're pushed and pulled for orthodontic purposes. But it's part of the periodontium that provides the attachment of the teeth to the surrounding bone via the cementum. So I like to call the ligaments little shock absorbers because they kind of allow our teeth to have a little bit of movement instead of being attached directly to the bone. Because if they were attached directly to the bone, it would be, they would be shorter. There'd be no give. So like eating a jawbreaker could literally break a tooth, right? So it would be, those things would be, although it can do that anyway, but I still love my fireballs. Anyways, all right, so microscopically, here's your periodontal ligaments, here's your cementum, and here's your alveolar bone proper, okay? Your little Sharpie fibers are on either side.
Ma'am, we can't see the, I can't see the.
Oh,
your
did I
screen.
forget to, thank you, ma'am. See, I was doing so good. It wouldn't have been a real day if I would have done it all right, right? Have to mess up somewhere along the line. All right, now can you see it? Let me go back. Hold on. So you've seen this picture like 4 times already today, but there you go. Here's what I was talking about. Here's your cementum. Here's your periodontal ligament. Here's your bone. So your ligaments, you know, they're in all different directions. You have your little Sharpie fibers that insert here and your Sharpie fibers that insert here, and that's where your ligaments go into, right? All right, so the periodontal ligament space is 0.4 to 1.5 millimeters on a radiograph. It is a radiolucent area or dark, and you can see it, let me use my little, you can see the little dark line in between, because here's your lamina dura, but then you have this little dark line, like you see right in here and right in here, that's your periodontal ligament. In between, so that dark line that's in between the lamina dura and the cementum is your periodontal ligament. It's very, very thin. The periodontal ligament is an organized fibrous connective tissue that also maintains the gingival tissue in proper relationship to the teeth. In addition, it transmits occlusal forces from the teeth to the bone, allowing for a small amount of movement and acting as a shock absorber for the soft tissue structures around the teeth, such as the nerves and the blood vessels. Other functions include serving as the periosteum for both the cementum and the alveolar process. Cells of the periodontal ligament also participate in the development and resorption of hard tissue of the periodontium. And additionally, the blood vessels that provide nutrition to the cells of the ligament and the surrounding cells of the cementum and the alveolar process. So they are very beneficial. Finally, the PDL and its nerve supply provide the most efficient perceptive mechanism for allowing us to feel even the most delicate forces applied to the teeth and any displacement of the teeth resulting from these forces, such as metal foil on a candy wrapper. Like, you know, that the tiny, or think about the fact that like, if you bite on a piece of hair by accident, right? Like that, you can, it feels like huge and like you have this big thing in your mouth. It's because of such a, you know, innervated area of, you know, to have floss get stuck in between your teeth. It feels like you have like a wedge or, you know, things like that. So unlike soft connective tissue of the pulp, the periodontal ligament not only transmits pain, but it also touch, pressure, and temperature sensation. All right, so even after patients have endodontic treatment, which is vital pulp where they have the root canal, where the root, the pulp is removed, the tooth becomes non-vital. They can still feel discomfort biting down because of the periodontal ligament, because that's still viable. It's just the inside of the tooth that is not. It's the sensation from the periodontal ligament. So, all right, there's your little piece of foil. All right, periodontal ligament properties. Similar to the alveolar process, the periodontal ligament develops from the dental sac of the tooth germ and thus is mesodermally derived tissue. So it's from the mesoderm. Because the periodontal ligament is a connective tissue, it has all the components of connective tissue, such as intercellular substance, cells, and fibers. It has mostly type 1 collagen, as well as lesser amounts of the other types. It has a vascular supply, lymphatics, nerves, and they all enter through the apical foramen of the tooth to supply the pulp. Two types of nerves that are found within the PDL. One is an afferent, which is sensory, which has the myelated nerve and transmits sensation. The other type is an autonomic, which regulates the blood vessels. So they have their vascular supply, they have nerves, they have lymphatic, they have afferent nerves, and they have autonomic nerves. One regulates, one is sensory, one regulates the blood vessels. All right. The PDL has all the cells that are found in most of the connective tissue, such as cells of blood and such as the cells of blood and endothelium. Here's your alveolar bone proper. I don't know what, let's see if I can find this picture. Oh, there it is. Here's your osteoblasts, okay? Because this is the forming bone. And this is your cementoblasts here. Here's your periodontal ligaments. These arrows are pointing to the rest of malaise within the periodontal ligament. That's what these are. All right, so, and like all connective tissues, the fibroblast is the most common cell. So here's your little fibroblasts. Here's your intercellular substance, and then your connective tissue fibers. This is your matrix, and you can see the little cells in there. And they produce fibers and intercellular substance. So, all right. Periodontal ligament also has cells that are not present in other connective tissues, such as a line of cementoblasts along the cemental surface of the root. Osteoblasts are also present in the periodontal ligament at the periphery of the adjacent alveolar bone proper. In addition, the PDL has osteoclasts as well as odontoclasts. So the periodontal ligament, just to sum this up, has both, it has osteoblast and osteoclast near the alveolar bone proper, and they have cementoblast and cementoclast near the cementum to help with that. So those are the cells that are in there. The epithelial rest of malaise, or ERM, are present within the PDL. These groups of epithelial cells are stranded in mature PDL after the disintegration of the Herwig's epithelial root sheath during the formation of the root. All right, so into our fibers. All of the fibers of the PDL are collagen structures. I've already mentioned that. Most of the fibers are considered principal fibers. Principal fibers are not found as individual fibers, but as organized into groups or bundles according to their orientation to the mature tooth and the related function. There's 5 groups. I'm trying to think of them off the top of my head. The principal fibers are not found as individual fibers. They're organized groups. Why are you repeating yourself? During mastication and speech, certain forces are exerted on the tooth, such as rotation, tilting, extrusive and intrusive. The principal fibers of the periodontal ligament distribute these forces, protecting the soft tissue and allowing some give when they occur. Similar to a rubber band attached to both ends of a hard object, in addition, the fibers can accomplish this task because the ends of each fiber are anchored to the cementum and the root. So it's like if you held a rubber band and they're anchored, but they can still kind of, you know, pull one side and pull the other. All right, we know this. Sharpie's fibers, 90-degree or perpendicular, right? All right, so the main principal fiber group is the alveolo-dental ligament, which consists of 5 fiber groups. The alveolar crest, anybody want to guess where that might be? Near, I'm going to say it, near the alveolar crest. Okay. Then there's horizontal. And then these are closer, they're right up here. They run perpendicular. Then there's oblique, which are on the sides. Some of the oblique are in the, on the inner side of the root. There are apical, which are found at the apical, the apex of the roots. And then there's interradicular, which is these groups that the touch near the bifurcation. All right. If viewed in a sagittal section from both facial and lingual, the view of the PDL of the fiber groups have different orientations from the cervix to the apex. They run, you know, they run in, you know, your gingival fibers can run around, but your periodontal ligaments run really just in that space in between your bone and your root. Here is your alveolar bone proper. Here is your cementum, your dentin, and here are your alveolar, your ligaments, your periodontal ligaments. Okay. Each of the five fiber subgroups, I'll say that five times 5, also has its own specific function related to the differing orientation of the tooth. So this is on page 193. I think we're gonna go, yeah, okay. So we have our alveolar crest group. These are the alveolar dental ligaments attached to the cementum just below the CEJ and runs in an inferior and outward direction to insert into the alveolar crest. Okay, so it's this, you can see it right over here. It runs straight out to the, this function is to resist tilting, intrusive, extrusive, and rotational forces. Then you have your horizontal fibers. They are just apical of the alveolar crest. They run at a 90-degree angle to the long axis of the tooth from the cementum to the alveolar bone process, just inferior to its alveolar crest. So just right below the crest, right below the CEJ, or below the alveolar crest group, you'll have your horizontal fibers, which are next. Its function is to resist tilting forces, which work to force the tooth to tip mesially or distally or lingually or facially, and to resist rotational forces. So think about it. If those teeth, you know, are tilting, you're like, there's, you know, bone has to go away for that tilting to happen. So therefore, messing with the ligaments. Your oblique group, it's the most numerous of the fiber groups. It covers the apical 2/3. So here's like, you know, the apical or the coronal third. It covers the majority of the root, right? This subgroup runs from the cementum in an oblique pattern. So instead of it being horizontal, it's more like at an angle. Its function is to resist intrusive forces, which try to push the tooth inward, as well as rotational forces. You can see here, here's your oblique. You can see them running all the way across there. And then you have your apical group. Your apical group, its function is it literally runs from the cementum around the apex to the surrounding alveolar bone proper, forming the base of the alveolus. So right down here. So here's your apical group. It's at the apex. Its function is to resist intrusive forces, which try to pull the teeth in an outward manner, and rotational forces. And then finally, we have our interradicular group, and these are found in between the roots of multi-rooted teeth. This subgroup runs from the cementum of one group to the cementum of another group. So it doesn't touch bone at all. It goes cementum to cementum. So it's just superficial to the interradicular septum, and thus has no bony attachment. This subgroup works together with the alveolar crest and the apical subgroups to resist intrusive forces, tilting, and rotational forces. I would highly suggest that you know this. There we go. Okay. Your interdental ligaments. So these are, you know, in between teeth, right? So another principal fiber, other than the alveolo-dental ligament, is the interdental ligament or the transeptal ligament. This principal fiber group inserts mesial to distal, or mesial and distal, or interdentally into the cervical cementum of the neighboring teeth at the height, at a height coronal to the alveolar crest. So you can see, but it's at the an apical to the base of the junctional epithelium. So here is your junctional epithelium right here, right? Here is your cementum. So it's going to go, here's your alveolar crest. So it's going to go across here. That's your interdental ligament. Here's your alveolar ligaments, or your, and then your alveolar crest, and then your oblique, your horizontal, more oblique. I guess this would be your alveolar crest as well, but here's all your obliques that you get there. All right, so again, this dark color is cementum. This is the dentin. Here's your enamel up here, and then your periodontal ligaments. And you can see there's some that run here. You can see the ones that run here. They run at an angle down here. All right, so here's your gingival fiber group. Some histologists also consider the gingival fiber group part of the principal fibers of the PDL. These are separate but adjacent groups that are found within the lamina propria of the marginal gingiva. So again, here's our marginal gingiva, right? From here, this is our marginal gingiva, this little piece right here, not all down here, but so not only do we have ligaments going from bone to cementum, but we also have fibers that go from the bone to the margin, like to the gingiva. So we have our dentino, the ones that go from the dentin to into the gingiva up here. And then we have our circular that run around. And then we have they go from the free gingiva to the bone, which is your alveolo-gingival ligaments, and then your dentoperiosteal, and they kind of run like the cementum does. So we'll go into this a little bit more. So the circular ligament circles the tooth, as shown. Like it's almost like you see the little purse in there. It's like that drawstring purse. It kind of pulls all the tissue tight around the tooth, right? Because the way it runs around. So it's a tight tissue that runs around. So that's why it's circular. It's like pulling like a purse closed. And then you have your dentinogingival. This is the most extensive of the gingival fiber groups. It inserts in the cementum of the on the root, apical to the epithelial attachment, and then extends into the lamina propria of the marginal or attached gingiva, which is this part right here and all over here. Thus, the dentinogingival ligament has only one mineralized attachment, and that's to the cementum. The alveologingival also only has that one attachment, but it's to the bone. And it radiates from the alveolar crest and extends coronally into the underlying lamina propria right here of the marginal gingiva. So there's your dentino, your alveologingival. And then your dentoperiosteal ligament courses from the cementum near the CEJ to the alveolar crest. This periosteal ligament anchors the tooth to the bone and protects the deeper PDL. It does not have Sharpie's fibers. So, again, orthodontic treatment or therapy, you're going to compress to have bone resorption, and then tension is going to deposit bone to make it for movement of the teeth. Occlusal trauma. I just peer reviewed an article for a friend of mine who is writing all about occlusal trauma and how it could be a causal link to periodontal disease, although it says here it is important to note that occlusal trauma does not cause periodontal disease. We tend to disagree. Her article was very important on that. It involves trauma to the periodontium from occlusal disharmony. It is important to note that occlusal trauma does not cause periodontal disease, but can accelerate the progression of existing disease with certain changes noted in the PDL. So if you have the ability, or if you are a host for periodontal disease, occlusal trauma could help, make that progression happen. Occlusal trauma that is placed on the tooth, it widens that PDL, that periodontal ligament. And then you can see in that arrow, from that arrow right there, and the width of the ligament can even double in size as the individual principal fibers thicken or become thick. And sometimes it is because that tooth is constantly being traumatized, you can get sensitivity with it because those periodontal ligaments are getting stretched and pushed a little bit. So you end up having maybe some exposure to areas that you wouldn't normally have, that are covered by gingiva. And sometimes it can cause sensitivity. So you can have a patient, now we can't do this, but the dentist, explain it to the dentist, and then the dentist could maybe fix their occlusion so that they don't have that trauma, or that they're not putting the forces on that occlusal forces on.
Question,
Did you have a
please.
question? Yes.
Yeah. So what's an example of occlusal trauma?
Clinching and grinding.
Oh, okay.
Or someone who falls and hits. But clinching and grinding, I think, would be especially with the stress in this day and age with pandemic, school. I mean, I've worn a night guard for 10 plus years because of the fact that I was, you can see the wear on my teeth from the clinching I do. So mainly my back molars. Does that answer, Ms. Silbert? Yeah.
Yes, thank you.
You're welcome. Radiographically, though, we're going to look for the thickening of that lamina dura. So in occlusal trauma. Mobility can happen over time, migration due to the further weakening of the periodontium due to occlusal forces. It's the, that constant I mean, this is the point where like I tell my patients, like this is like walking up to a fence post every single day and hitting it with a baseball bat like 10 times. Eventually that post isn't going to stay because it's being rocked, right? All right, so pathologic tooth migration. That's the, it's caused by the weakened periodontium in which the occlusal forces need to be in an abnormal level for the so like you can see, this is what this is. These teeth right here, see how they occlude on one another? You can see that there's like a fracture in this one, the way this one wears, and look at that tissue there. It's red because of the constant, even here, that constant occlusal, like your tissue's just angry. It doesn't want to be beat up every day. Periodontitis. The PDL undergoes drastic changes with the chronic advanced periodontal disease that involves the deeper structure of the periodontium. The fiber group of the PDL or the fiber groups of the PDL become disorganized, and their attachments to either the alveolar bone proper or the cementum through the Sharpey's fibers are lost because of the resorption of these two hard dental tissue types. So periodontitis is a microorganism or a bacteria that starts the destruction process of the fibers, the gingiva, all that healthy tissue. It starts to destroy it. The first fibers that are involved in the periodontitis are the alveolar crest group. Okay, that's you can see the circle there where it should be and where it is now. So that's a good test question right there. First fibers to be involved in periodontitis are the alveolar crest group. Periodontitis is the destruction of the PDL with periodontitis, then progresses further in an apical manner, similarly to the destruction of the alveolar process, affecting in order the horizontal, then the oblique, then the apical, then the interradicular if present. The teeth involved in advancement of periodontal disease become increasingly mobile, moving in directions that indicate the amount and the type of fiber group lost, such as buccal to lingual or with a downward pressure as the periodontitis progresses inward to the apices of the teeth. So as the destruction happens, you might get, your 1 millimeter back and forth. And then it keeps going, you'll get your 2 millimeters back and forth. Then it keeps going, and then it's on a trampoline and it just wants to bounce up and down. No. Okay. Periodontitis is going on again. That's the principal fiber groups that remains the longest in the presence of active periodontitis, despite the previous destruction of the entire adjacent alveolo-dental ligament, is the interdental ligament. So that one remains the longest, even though it's kind of the top that comes above. The bacteria usually is going into the sulcus, and then it breaks that epithelial attachment and progresses. And as it progresses, that epithelial attachment, those periodontal ligaments start to disintegrate, and that's why. But you still keep that inner radiculum or that inner ligament, that interdental ligament. It keeps reattaching itself in a more apical manner. The interdental ligament does, as the periodontitis proceeds apically, so that the teeth are at least held in interproximal contact. Thus, when teeth become severely mobile interproximally from mesial to distal after mobility in other directions are already present, the prognosis is poor because now there is further destruction of an interdental ligament. 4 weeks ago, I think I told you guys about this patient. It had been a year since he had come in for a dental cleaning because of COVID. He didn't leave his house until there was a vaccine. He went and got the vaccine, and then he didn't leave his house until the next vaccine. Like, He literally did not leave his house until he was fully vaccinated for 2 weeks, except for to go get those vaccines. And he came in and he was a periodontal patient. He used to be on a 4-month recall, and he came in, it's been well over a year and a half at this point. And number 9, there was so much destruction that, and because he occlusal trauma, his front teeth constantly hit on one another, that number 9 was like, the prognosis was extremely poor. Like that tooth was not going to be saved. And it's all, you know, I don't know what it would have, it wasn't like that when he came in a year and a half ago, but it's just the destruction happened. So, all right. Let's see. I'm gonna stop sharing. All right. Ask a few little, you know, let's see if you remember what I talked about here. Okay, so I'm looking at some. Which of the following correctly describes the dento-cemental junction? So that's the dentin and cemental junction. It is a very well-defined interface clinically, appositional growth of the cementum over dentin, very well-defined interface microscopically, or interstitial growth of the dentin over cementum. It's a lot of words to not have on the screen. Hold on.
Was it the second one?
It is B. As a result of the appositional growth of cementum over dentin, the dento-cemental junction is formed. The interface is not as defined, either clinically or microscopically, as that of the dentino-enamel junction. Given that cementum and dentin are derived from a common type of tissue during development, since both the dental sac and the dental papilla are originally derived from the ectomesenchyme, therefore, both are mesenchymal in origin. Do you guys go onto the book website and do the practice quizzes?
I didn't know we had them for this book.
Yep. Yeah, Elsevier, who makes this book, they're really good about that. They have lots of practice quizzes. Yeah. Let's see. Which of the following is not visible? Which of the following is not visible at all on a radiographic bite wing? The periodontal space, the lamina dura, the cortical bone, or the trabecular bone?
Cortical bone?
Good. Yep, cortical bone. Which part of the alveolar process is the loss of bone from periodontitis evident? First evident, excuse me.
Is it the alveolar crest?
Yes, very good. With occlusal trauma, there can be widening of the periodontal space, periodontal ligament, lamina dura, or periodontal space, periodontal ligament, and the lamina dura.
PDL?
I believe you're right. I'm just double checking myself. Early occlusal trauma can be viewed on a radiograph as a widening of the widening of the radiolucent, so it's D, it's all of them. So it's the periodontal ligament space, the lamina dura, and you get the thickening of the lamina dura, the ligaments, then, oh, I can't remember what I said up here, hold on. I'm exhausted, you guys, I know that. 86, 86. Yes, periodontal space, periodontal ligament, and the lamina dura. Most common cell of the periodontal ligament. What makes the periodontal ligament?
Is it fibroblasts?
Fibroblast. Good job. The bone in between two neighboring teeth is called?
Interdental bone.
Good job. Come back up here. We'll start from which cell type is not renewable after, like, looking at the whole tooth, all the different cells, ameloblast, odontoblast, osteoblast, and cementoblast. Which one is not renewable during the lifetime of the tooth?
Would be a ameloblast?
Yes. What makes the enamel matrix? This is kind of an easy because she just said it.
Ameloblasts.
Ameloblast. Yep. Enamel forms in what shape?
Is it hexagonal?
So it's a crystalline structural unit of enamel, but how is it formed? What do we call them? Enamel what? Enamel rods. So like they form in little rods. Yeah. Let's see. Know the difference between the Tomes granular layer, the lines of rhexis, pericomata. I feel like this is a very heavy definition. Which of the following represent short dentinal tubes located near the DEJ within mature enamel? These are there's that picture that had all the different. Short dentinal tubes are the enamel spindles. Know the different, because they're all, and I kind of went over that the other day. The enamel tufts, the enamel lamella, the enamel spindles, the enamel rods. Enamel matrix is a blank product because ameloblasts are derived from the inner enamel epithelial organ. Epithelium of the enamel organ. Are they ectodermal, endodermal, mesendermal, or neural crust cells?
Is it endodermal?
Mm-hmm. Okay. Percentage of mature, what is inorganic material of enamel is what percentage?
96%.
96, very good. All right. What can happen due to excessive amounts of systemic fluoride?
Fluorosis.
Yes. And dental fluorosis is a form of I think it's enamel dysplasia. Where did I put that? Mhm. Okay. Let me make sure that that one's right before I. Yes. So dental fluorosis is a type of enamel dysplasia. Okay. Any questions? No? Okay. Monday, we will do our test. It'll be 50 questions and it'll be on chapters 12, 13, and 14. And then we get in to teeth. So excited. This will be fun. So, okay. So if no questions before we go, you guys have a
personal question just after.
yes.
I have a question too.
Alicia, yes, it's okay. I'm here. And then go ahead, Ms. Filbert. Do you have a question? Do you want to ask after?
I can ask now. I just want to find out the drawings that we submitted. I didn't put my own online before I submitted. It's showing missing. So.
Oh no, don't worry about that. You don't submit it online. I had put them as a submit, like, so that if people wanted to submit them online, but you're not, that'll be fixed.
Okay.
You're not late. Don't worry.
And for the drawing, is it the left canine or the right? Because on Canvas, you have them both, but on the syllabus, it says left, I think.
So I went right central, left lateral, right canine. If you do the left one, I'm not going to mark you wrong, but
So we're doing the right
canine. But you're doing the right. And then premolar, you're going to do a lower left, and then molar, you're going to do first right. I kind of kept them back and forth, so I try to keep a pattern with myself, or else I'll lose my mind. So, okay, good question. So yes, left canine is due Monday. I mean, right canine is due Monday. Sorry about that. Right canine due Monday. We have a test Monday, and then that's it. I think, then we.
Don't we have another workbook too?
Yes, you do have the workbook. Sorry. You have 12, 13, and 14 due. Mm-hmm. Yep. So, all right. So workbook, test, drawing, due Monday. Okay. Anything else? So is that it? So I know Alicia is staying with me after. Filbert, Amanda, you need to ask me a question?
Yeah, just after.
Okay. All right.
I think I'm done. Yeah.
Okay. All right. Well, you guys have a good weekend. See you Monday at 9. Or are you tomorrow, Hojin, at 9? Hold on, Levi. I don't know if I'm going to go ahead and stop.